Everyone, I think, has an attitude and different things help. Use what you can. Prayer, people, connecting, up until the very end, this helps. As far as the attitude, how about it's okay, it's normal to be afraid. It's okay to want to fight it. And sometimes it's okay to give up. Being on hospice allows them to talk about it more so, and I think that's a benefit.
Hello, and welcome to Not Born Yesterday, a podcast dedicated to older adults and the challenges and joys of aging. I'm Miriam Goodman. Not Born Yesterday is an award-winning program providing expert advice on issues related to older adults, their adult children, and anyone who works with or lives with elders.
Not Born Yesterday is brought to you by Next Village SF, providing services and support to older adults, and the Fromm Institute for Lifelong Learning. I'm Lynn Winter-Gross.
Today on Not Born Yesterday, we're discussing hospice care. Unless you've been involved in hospice for a family member or friend, you may not know very much about it. So we want to explain what it is, why it's so helpful, and also dispel some myths and misinformation. To qualify for hospice care, 2 doctors must certify that the patient has a life-altering condition with life expectancy of less than 6 months. Hospice care focuses on the quality of life when cure isn't an option or the patient chooses not to undergo certain treatments. It aims to keep the patient comfortable and focus on pain and symptom management. When one signs up for hospice care, he or she gets a team of professionals trained to address physical, psychological, and even the spiritual needs of the patient. The hospice team also supports family members and other unpaid caregivers. And although we usually think of hospice care for older adults, it's also available for children and adolescents.
Although half of all Americans now die in hospice care, many patients who could benefit from hospice don't know about it, or they enroll at the very end of their life, missing out on many of the benefits. Medicare and most other health insurance plans now cover the cost of hospice. Our guest today is Karen Gordon, a Washington, D.C. area psychiatric social worker who spent years working as part of a hospice team, as well as working with the chronically mentally ill. Karen, welcome to Not Born Yesterday.
Well, thank you. It's nice to be here.
Let's start at the beginning. Hospice provides comfort, dignity, and emotional support for patients and their loved one. It's not about giving up hope, but helping patients to restore relationships, find peace, and have time without medical intervention. This sounds nice, but how does one get over that barrier of end of life and accept that it might be really time for hospice?
Well, I think you explained hospice very well. It certainly is to help with all sorts of various type of illnesses with a limited life assessment. How do they get over using hospice? Their doctor refers them, as you said, and a lot of them think, well, gee, once I get on hospice, I have to stay on. Not true. They can stop anytime, okay? And some of them fear that they're going to be losing control of the medical decisions. This also is false. They're able to decide with the hospice nurse, their own doctor, the care, and it's usually is for comfort. And I think that if families know that they're going to have so much support, as you said, not just physical, but emotional, that they would be much more open to embracing it. It includes educational support. The nurses train the families how to care for the patient. Emotional support. The whole staff provides that. A lot of it is validation of feelings, reassurance, and then help with resources. All of this, and the family knows that they can contact hospice most any time, I think allows them to relax just a little bit more in a very difficult, overwhelming situation.
Does someone have to be bedridden or clearly at the end of life to call hospice? And how long does it last? We hear 6 months, and then we hear that President Carter has been on it for a long time.
Yes, he's our interesting person on hospice. It usually is 6 months or less.
Are they still taking medicine where they're on hospice, or does hospice mean no more
Oh,
medicine?
yes. Yeah. And yes, the other question you say, are they bedridden? Not necessarily. They usually end up that way because of the illness. Yes, they take medications, certainly for pain comfort, and it depends on what they're taking. They probably would not do medications that, an experimental thing that's going to try to change and cure the cancer or whatever. Oh, and by the way, it isn't just cancer, it's all sorts of illnesses and this is important for people to know that whatever it is that they can get on hospice, if they are terminally ill.
But you mentioned just a minute ago something about if there's new advances in medicine or something. So if a patient hears about it and says, maybe I don't have to die right now. Maybe I should try that experimental thing. What happens? They just go off hospice?
Well, I think if they discuss that with the hospice team and their doctor, they may still be able to stay on hospice. But they can go off hospice and come back on.
So I want to ask you, I'm a little confused. Does somebody get on hospice when a doctor recommends it?
Yes, and of course, insurance covers it. And this is important to know, Medicare, Medicaid, and private insurance. And the doctor will recommend it. And you know what? They don't know how long it's going to be. Okay, I think that's important. And that's one of the big supports that we give to the family and the patient is helping them with their questions. The nurses actually train the family and how to care for them, but also validates their feelings. A lot of times families are ambivalent. They see their loved one in pain or suffering, or they're exhausted. And so one of the roles as a social worker is I might go in and help them verbalize some of their guilt that they, wishes it was already over, and normalizing everything.
I assume you were with many patients at the end. What is their state of mind like? Are they open to talk about their feelings, and do they talk about their regrets? Do you have any specific cases you could talk
Oh,
about?
sure. Well, let me start. When my first day at hospice, and my supervisor, a hospice nurse, took me to meet a patient who had been on hospice for a couple of months already. And this woman, yeah, she was dying, but and she knew it, of course, but she was pretty strong. And so when I went to greet her, and I had on my serious professional face, and I, wanted to see how this went, and she said, "Well," in a strong voice, "I hope you're not going to be one of those doom and gloom social workers." I immediately put on a smile and said, "I sure hope not." This really helped me to learn to be authentic, as you want to, with any social worker should be with their clients, and to help them where they're at. So she didn't mind talking about it, and many talk about it. And obviously, there are some who don't even want to think about it. When I came to DC, if I was a hospice worker first in Pittsburgh and then DC, I met a man, and I like to just socialize, talk about, who he is and maybe what he did. So I said, well, and he was older, he way retired 20 years. I said, well, what kind of work did you do? And he was quiet, and he looked at me. So I joked. I said, okay, if you're a spy, you don't have to answer. And he said, oh, that's good. I said, oh my goodness, I'm in DC. Yes. Anyway, but we meet all types of patients and families too.
Well, you'd mentioned that you kind of learned on the job the very first day that people are different, but I wonder, do hospice workers get extra education before they become hospice workers? They're already trained social workers or nurses or doctors, but is there a special thing about empathy or emotional support?
I don't think so. I think that we learn, and I'm a clinical social worker, and I think that we learn to treat people, whether they're family, psychiatric patients, you name it. I've worked with drug addicts a lot, the same, with empathy, with respect, and allowing them to, and especially, I don't think there's any special training. I think that you learn, though, you want to make their life meaningful. And as much as possible, whether it's their life or they're dying or whatever. I had one man, I went to this family and they greeted me at the door, very gloomy. The patient was in a bed in the corner of the room, and they said, he won't talk, he won't eat. The doctor says, he's not quite ready to die. His eyes are shut and he's just given up. And so I didn't have much hope, but okay, I went to talk to him and he didn't respond. Eyes shut, face turned away. I knew that he knew he was dying. So I asked him, tell me, is there anything special or specific that you want to have at your funeral? And all of a sudden, he opened his eyes. This old man looked at me and he said in a very frail voice, nobody has asked me about that. And then in a slightly firmer voice, he says, yeah, I went, and he told me what kind of music he wanted, what prayers he wanted, actually who he wanted and who he didn't want to come to his funeral. And I said, okay, that's meeting the client where he's at. And that's a social work theory that we follow.
So you're a social worker, but there's also nurses that come and a medical team?
Definitely. Nurses aides, a chaplain, and I have a chaplain story too, and volunteers. Volunteers are so important. They no longer can be hands-on because of liability, but they'll do things like relieve the family and sit with the patient, maybe get him a meal, they'll write a letter, other social media, they'll even walk the dog. You name it, the volunteers are very important. And the chaplains, they're there, the hospice staff all works together. I had one woman, she was a mother superior, and I sat with her a couple of times. I went to the convent, and she said on the third visit, Karen, I have to tell you, I have to share with you something I've never shared with anyone, especially here. And I said, well, okay, what is it? And she said, I'm terrified. I'm terrified of dying. Here's the mother superior, and she couldn't open up to anybody because she was the role model that they all looked up to. She told me about her fears. I didn't give her any solutions. I just listened, and that's what she needed.
So can you describe when somebody calls hospice, what happens? A team comes into the house, and then what?
So when a family calls hospice, and I believe they sign an agreement, and this is with their doctor's blessing, and they do not lose contact with the doctor, okay? Although we have hospice doctors also who support the staff. The nurse goes in, evaluates the patient, talks to the family, makes sure they have the resources they need. She might order a hospital bed or anything that they need resource-wise, and they sign an agreement. I don't know if the patient has to, but somebody just that they agree to have hospice. And so they get explanations of what to expect and how often that they're going to get the help. Usually the nurse goes in once a week. A nurse's aide goes in 2, maybe 3 times a week. She'll help to bathe the patient, feed him, wound care, whatever is needed. And again, all emotional support. The social worker might go in once a week, the chaplain as needed, all of this, and then volunteers. So they're given all the information, told that they can call hospice as needed, which is a nice relief. And basically, they are the ones who are doing most of the hands-on care.
And I think it's important to remind people hospice is not to replace a caregiver. If somebody
Right.
has a professional caregiver there, that person still stays. Which leads me to the question, who's really in charge? You talked about how they come in and they get people to sign on, but if there's some kind of a crisis, is it the patient who's in charge? Is it the hospice workers who's in charge? Who makes that decision? The family member? Who is it?
It depends how alert the patient is. Okay, they can make that decision. Usually they would make it with the family. And I'm not sure decision wise. I mean, let's say the patient is in pain and the family would call their doctor or the hospice nurse. The hospice nurse might call the doctor to get more pain medication. So I think it's very much the family is part of the team, and as able, the patient as well.
Does hospice care work with the family after the patient has died to do grief counseling and bereavement counseling?
They usually have bereavement counseling, not exactly the same staff.
So
Yeah.
many patients are definitely in physical decline. They have pain, weakness,
Right.
fatigue, etc. when you see them. But what about people with dementia who don't necessarily have physical pain? How do you deal with them at their end of life?
As you would probably with before end of life, with as much respect that you could give them. Sometimes they would, if they're really, really out of it, you more deal with the family. Okay. But the pain control, just as you would anybody with dementia, I guess. It doesn't have to be separate because of that they're dying.
Karen, what is the difference between palliative care and hospice?
Uh, Palliative care might involve other type of procedures. It is to do, pain control. It's very close, but hospice care is more making the patient comfortable physically. Palliative care may involve other type of techniques.
So for those of us who are like the mother superior that you talk to who are afraid of dying, you've been
Yeah.
around a lot of people who are dying. Is there anything you can tell us about how we should not be so afraid of it?
Everyone, I think, has an attitude and different things help. Use what you can. Prayer, people, connecting. Up until the very end, this helps. As far as the attitude, how about it's okay, it's normal to be afraid. It's okay to want to fight it. And sometimes it's okay to give up. Okay. I think that being on hospice allows them to talk about it more so. And I think that's a benefit.
I would like to know if people talk to you about their regrets in their life that they wish they had done things differently.
Yes, that is definitely true. And sometimes it's the family members who are not dying, but they talk about their regrets that they weren't able to do more with the patient, or they weren't kind enough. Whatever it might have been, those regrets are part of it. Or that we didn't play more. My goodness, he retired and then he got sick. We never had a chance to even go on a vacation. And the patients also. Yes, I think that is certainly something that they look at their life, they evaluate it, and hopefully come to accept that there was little they could do, looking back, and help them to accept the regrets.
So, Karen, I've talked to some volunteers who worked with hospice, and one of their biggest regrets is that they lose contact with the family after the patient dies. They feel like they were sometimes part of the family, sometimes had meals with them, came in and really was part of it. And then the person dies and they're completely cut off. And I think that's the policy of hospice. Is that correct?
I think it tends towards that. I think they could go to the funeral perhaps, but they're discouraged. Certainly hospice staff does not keep contact with the patients or with the family. But I can understand why they're upset. They might spend a couple of months, a year, whatever it might be, with a family, helping them, talking to them, becoming like family themselves. And it's very abrupt for them to have to cut it off. So I understand that they have that negative feeling. But they get involved with another family after that, and I think, they grow and they go on.
How does one become a volunteer?
Oh, that's a great question. They contact the hospice program in their area. And I have to tell you, the volunteers often say, oh, I got so much back from the patient, from the family, far more than I gave to them. So they find it a very rewarding experience.
What if the family members disagree on what should happen? Some say, I'm ready for my loved one to die peacefully, and the others say, no, I think we should keep this person alive.
That's a very tricky question, and I think the family has to figure out for themselves, along with the patient, if the patient is alert, what direction. The hospice does not make that decision for the family. They might provide information, like what to expect when the patient is dying, what symptoms would they be looking for. And I always was amazed that the hospice nurses knew sometimes within the day, a few days, when the patient was going to die.
Thank you so much for explaining hospice and the benefit it can offer patients and their families. Our guest was Karen Gordon.
It's been my pleasure. Thank you.
Today on News You Can Use, we're reminded that historically, many people have counted on their children to take care of them as they age. In fact, didn't we learn in elementary school that farmers and other non-industrial workers intentionally had large families so the parents would have help on the farm and be secure in retirement? Well, just like almost everything this generation has been doing to reinvent common practices, many of us are now approaching retirement or already there, and at least 20% have no children at all for that extra protection or support. There are important implications for society as a whole, as perhaps 1 in 5 adults will have no adult children to help them with the tasks of daily life. According to Sarah Zeff-Geber, a retirement coach, there are special considerations for retirement and aging among those who do not choose to bear children.
Of course, everyone should make plans when they're older, but when parents fail to do this, most of the time, one or more of their offspring will step in to do it for them. This is especially true when it becomes an urgent issue like moving into senior living, making decisions about home care, or helping out in a crisis. Dr. Geber said there are things solo agers can do to plan for those later years. She suggests that you reinforce your social support system while you're still active and healthy. You probably know other solo agers, and you might want to think about developing some agreements with them for how you can care for one another in later life. Here's some suggestions. Arrange to live near one another. Research communities that you can afford and agree what would be a nice place to live. Some have already created co-housing communities. Others have purchased small apartment buildings.
You should create legal documents. Consider using durable powers of attorney for health and financial issues, listing one another after a spouse or partner may have died. This way you know that someone who knows you will make decisions on your behalf and according to your wishes.
And if you can, include younger people in your group. If you're lucky enough to have nieces and nephews you trust, or younger adults to whom you are close, include them in your planning. Or you can hire a geriatric care manager for your group who can oversee your collective needs.
We are all reinventing ourselves as we age, but for now, consider that plans must be made, whether or not you have children. It will make the journey less stressful and give you the peace of mind you've always wanted.
And that's our podcast for today. Our thanks go to our guest expert therapist, Karen Gordon. You can learn more about Next Village SF at their website, nextvillagesf.org. Our theme music is from Hook Sounds, and Jason Dahlstedt is our engineer. And we thank you for listening. We would love to hear what you would like us to discuss and discover. Please contact us at notbornyesterdaypodcast.org. You can follow us on Facebook and Instagram and subscribe wherever you listen to podcasts. All of these are free and help us to know our audience better. Be well, stay strong, and remember, you weren't born yesterday. I'm Lynn Winter Gross.
And I'm Miriam Goodman.